Moving down our list of pituitary adenomas, the next most common specific type of tumor is a growth hormone secreting adenoma. Take a moment right now, pause the video, and try to review in your mind what growth hormone's actions are. If you watched the physiology video, you may remember it as growth hormone, the orthopod bodybuilder. Remember, as an orthopod, he's all about the muscle and the bone, with the induction of muscle growth and bone growth, but in his quest to get huge, he causes hypertrophy of the internal organs as well. The bone thickening leads to a very recognizable syndrome called acromegaly. It's most visible in the face. To show a really dramatic example, this gentleman right here demonstrates the classic look pretty well. The facial features become, for lack of a better word, more cavemanish, and specifically the mandible thickens a lot, causing the lower but not the upper teeth to start forming gaps. Finally, the hands and the feet become bigger and thicker. Acromegaly is often associated with tall stature, but that only occurs if the hypersecretion began before the epiphyseal plates closed. While the bony changes of what make acromegaly so recognizable, the soft tissue and organ hypertrophy lead to a lot of the more serious complications. Tongue and laryngeal swelling combined with muscle hypertrophy produce the characteristic deep, thick voice of patients with acromegaly, kind of like James Earl Jones talking through a mouthful of peanut butter. Hyperplasia of the GI epithelium leads to a greater instance of colorectal polyps and cancer. Finally, in patients that have increased growth hormone from a very young age, cardiac hypertrophy is a very real risk and a major cause of death in these patients. Diagnosis with growth hormone is impractical because of its pulsatile secretion, but remember what the substitute value we use is? Diagnosis with growth hormone levels is impractical because of its pulsatile secretion. Remember what the substitute value we use is? Insulin-like growth factor 1, or IGF-1, is another hormone that mediates many of the actions of growth hormone and is much more stable. You can also use the glucose suppression test to see if growth hormone bottoms out like it's supposed to after an oral glucose load. This is kind of like the dexamethasone suppression test. If you give the patient something that should decrease their hormone output, in this case glucose, and it remains high, then that indicates that there's a pituitary tumor running amok and secreting way too much GH. Finally, you can use a pituitary MRI to localize the tumor. If there's no pituitary tumor, you may also be dealing with growth hormone abuse, which is less popular than steroid abuse, but still pretty prevalent amongst bodybuilders. The treatment for acromegaly is still largely surgical. The results with medical suppression simply aren't as well established. But the options for medical therapy are octreotide, which, if you remember, is a somatostatin analog that blocks GH, and pegvisomant, which directly blocks the effects of GH on target cells.
The converse of this, of course, would be a form of dwarfism. It's called Laron's syndrome, which, full disclosure, I have no idea how to actually pronounce. It's named after an Israeli endocrinologist, if that helps you any. Laron's syndrome isn't as common as achondroplasia, which is a disorder of cartilage ossification that you can read about in the musculoskeletal section. This disorder actually involves a normal pituitary, but a defective GH receptor. Like achondroplasia dwarfism, the presentation is characterized by disproportionately short limbs, which should make sense because GH is responsible for long bone growth. But unlike achondroplasia, which is characterized by a proportionally large head and a pretty normal-looking face, these patients have proportionally small heads and noticeably dysmorphic faces. I couldn't find a picture that wasn't copyrighted, but Google search it. You'll see a couple examples. The key finding is the unusual saddle nose and the fact that the face is about proportional to head size. With achondroplasia, the face generally appears small compared to the head. Finally, male patients with Laron's syndrome have the unfortunate predisposition towards micropenises, which, as far as I know, isn't found in achondroplasia. But, you should probably just ask a person with achondroplasia just to make sure. Laron's syndrome can be suspected by physical exam alone, but is conclusively diagnosed by measuring GH and IGF-1 levels. So tell me, if the GH receptors don't work, is the circulating GH going to be increased or decreased? Remember, there's nothing wrong with the pituitary, but if its GH receptors are telling it that there isn't any growth hormone, it's going to assume that it needs to bump up the growth hormone production. Of course, since IGF-1 is a hormone that requires GH stimulation to mediate its effects, IGF-1 will be decreased.
Let's talk about some disorders of vasopressin. Now think back to physiology. What is the single most important purpose of vasopressin? Hint, you can sum it up in one word, and that word is osmolality. True, it's a crucial hormone of fluid retention just like aldosterone, but unlike aldosterone, which promotes isotonic saline retention, vasopressin promotes free water retention. This allows it to decrease serum osmolality by reclaiming free water from the urine and concentrating it. Diabetes insipidus, which means large amounts of bland pee, is basically when vasopressin ain't doing what it's supposed to. While it seems like it has nothing to do with everyone's favorite type of diabetes, consider that the most common presenting symptoms are very similar. Polyuria, which is peeing a lot, and polydipsia, which is drinking a lot. Now normally if the patient drinks enough water, they can stave off dehydration, but if they don't, then the lack of fluid retention in the kidney will lead to fluid loss and eventually dehydration. More importantly, the patient's loss of free water will increase the serum osmolality, generally to above 290 milliosmoles, and decrease the urine concentration, usually below a specific gravity of 1.006. And if you didn't remember, by the way, a specific gravity of 1 is pure water, so that's pretty darn close. So there are two major ways the signaling pathway can go wrong. The first way is through decreased secretion of ADH, and that's called central diabetes insipidus. And it's very important you know how this can occur, because it's not always that intuitive. So you have your whole gamut of stuff that can affect the brain, like autoimmune diseases and infiltrative diseases like cancer or CNS infections. A lot of the cases are idiopathic, which is about par for the course, but a couple of the causes are really interesting. Before I tell you, which part of the pituitary is vasopressin secreted from? It's the posterior pituitary, which is really just the hub of all the axon terminals that come down from the hypothalamus. And that thin, fragile little stalk that carries down all that ADH to the posterior pituitary, it's pretty easily damaged. Blunt trauma to the head can shake the brain around pretty good, while the pituitary is actually sitting pretty securely in the sella turcica, so the stalk can even get stretched or even get completely transected, leading to diabetes insipidus. This is one of the situations that I've seen a couple times on step 1, which is weird because patients with blunt head trauma usually think of common stuff like concussions or subdural or epidural hematomas. But for extra credit, what's the other important intracranial structure that can get sheared during blunt head trauma? It's the olfactory nerve. Anosmia after getting conked in the head is also reasonably common. Finally, both pituitary adenomas and the transsphenoidal surgery used to remove them can damage the posterior pituitary, the stalk, or even the hypothalamus, and cause central DI.
But even if ADH is released normally by the pituitary, doesn't mean you're out of the woods yet. Nephrogenic diabetes insipidus occurs when tubular epithelial cells of the nephron don't respond appropriately to ADH. Now, the most intuitive etiology is the familial form, where the ADH receptor is mutated in such a way that the signal can't appropriately be transduced to the epithelial cells. There's also a number of drugs that can cause nephrogenic DI as a side effect, and these are important to remember. The one most associated with nephrogenic DI is lithium, and the second one to remember is a tetracycline antibiotic known as dimeclocycline. Lithium's really the most important one to remember, though. Dimeclocycline actually really isn't used much for its original purpose as an antibiotic, but the reason you might need it is if you have too much ADH. More on that later. Finally, remember that sodium transport is coupled with the transport of other electrolytes. Specifically, it's exchanged with potassium via the sodium-potassium ATPase and coupled with calcium transport in the loop of Henle. That means that if tubular calcium is too high, too much sodium will be transported out with it. And if potassium in the tubule is too low, not enough sodium in the tubule will be antiported in. Don't think about that one too hard. The mechanism's kind of outside the scope of step 1, but you should know which electrolyte abnormalities are associated with DI. So, how do we tell what kind of diabetes insipidus we got? And more importantly, why do we care?
Well, first of all, we definitely care because the treatment for each differs humongously. Differentiating between them is a little bit easier than differentiating the cause of calcium metabolism, but you can still expect a lot of very similar lab value-based questions. Before we get into that, what's another condition that can cause you to drink a lot of water and pee out a lot of very dilute urine? If you think about that for a moment, you realize that'll actually happen to literally every single one of you if you drink way too much water. This is by far the most common quote-unquote condition that gets confused for diabetes insipidus on initial presentation. Now, primary polydipsia is sort of the umbrella term for drinking too much water and peeing too much to let it all out. But when it's caused by a mental compulsion to hydrate or a psychological thirst that's way in excess of what you need, you call that psychogenic polydipsia. There's a couple of tests you can run to distinguish these three conditions, and you can start by measuring the baseline urine-specific gravity or serum osmolality. Remember, as you just saw in the lab values, the urine concentration is normally above specific gravity of 1.006. The serum osmolality is usually below 290 milliosmoles per kg, and the sodium is usually below 145 mg per deciliter. In diabetes insipidus, we know the urine-specific gravity is supposed to be low, and the serum sodium concentration and osmolality are supposed to be high. What about a person who's only peeing so much because he or she is drinking a lot? Now, clearly the urine is still going to be very dilute. We know this. But their serum osmolality and sodium will tend to be lower than normal as well, because in extreme cases, they're putting more free water into their bodies than their kidneys can effectively offload. Now, here's the problem with these baseline values. Usually, the deviations from normal are mild enough to be completely unreliable for diagnosis. The reason why is because electrolyte homeostasis is so important that there's almost always a mechanism in place to try to normalize the sodium and the osmolality. In primary polydipsia, the problem is the person's free water intake is way too much, but since their ADH signaling system's still working, their kidneys can still upregulate free water output to at least partially compensate for the increased input. We're assuming for the purposes of this diagram, by the way, that our patient's a male. Similarly, a patient with diabetes insipidus, for whatever reason, has humongous uncontrolled free water output from the kidneys, but if they have access to water, they can increase their free water output to match. One important thing to remember about this is that a couple of the causes of central DI, things like blunt head trauma or encephalopathy from, a CNS infection or the like, may make the person so altered that they may not be able to access water and drink to the extent that they should. In these cases, the deviations in serum osmolality will certainly not be mild. They'll be pretty extreme. The solution to this problem is to restrict the water input and then see what happens to the output. The water restriction test is basically what happens when you monitor the patient after taking some baseline labs and see how their lab values change after that. It's practically torture for these patients, but the information you get is pretty good. In a patient whose main problem is drinking too much, would you expect that withholding water would change the lab values? Absolutely. Once you stop with the crazy amounts of free water intake, the kidneys will normalize the serum osmolality and sodium concentration in response to the decreased water intake. And the kidneys will eventually increase the osmolality of the urine. Now, this represents a normal response to water restriction. Concentrating the urine in response to decreased water intake means that the ADH signaling pathway is working to keep serum osmolality constant. Now, a patient with diabetes insipidus, however, will show minimal change in urine osmolality because they're physically unable to concentrate their urine no matter how much you stop them from drinking. But what do you think is going to happen to their serum osmolality and sodium if they're losing all their free water in their pee and are prevented from replenishing it by drinking? Their serum osmolality and sodium concentration are going to go way up. And these guys need to be monitored because they can actually get seriously dehydrated as a result. This represents an abnormal response to water restriction that tells you that you've got diabetes insipidus and aren't just fooling around with psychogenic polydipsia or people who are drinking too much. What it doesn't tell you, however, is what type of DI you have. So to figure out whether it's central or nephrogenic, you give them desmopressin, which is a vasopressin analog, immediately after you've water restricted these patients. Vasopressin, which acts on the kidney, should cause increased urine concentration at this point, but which diabetes insipidus will show a response? The answer is central diabetes insipidus because their disease is just caused by a lack of vasopressin. So if you give them vasopressin, they should exhibit an increase in their urine osmolality of at least 50%. And they should have this almost immediately. Their serum concentration of sodium will also begin to normalize after vasopressin is administered. Nephrogenic DI, on the other hand, won't show any change in either of these values when vasopressin is administered because they already have enough ADH. It's their idiot kidneys that don't know what to do with it. Now, the treatment for central DI is pretty straightforward. If they're lacking vasopressin, then you give them a vasopressin analog. If the patient is drug-induced nephrogenic DI, Like after starting lithium, then for the love of God, try them on something else, like valproic acid or I don't know, something else. If it's hereditary nephrogenic DI, or if the patient will literally go crazy without their lithium, it's a lot trickier. The solution's pretty counterintuitive. You give them a thiazide diuretic, plus or minus a K-sparing diuretic like amiloride. Now, the best way I've heard it explained, diabetes insipidus is more likely to cause an osmolality than a volume problem because of the many other compensatory mechanisms for controlling fluid retention. But a mild diuretic will cause just enough volume depletion to scare the body, quote-unquote, into increasing proximal tubular resorption of saline. And since it's in the proximal tubule, the urine gets reabsorbed before it gets to the distal tubule, where ADH can completely screw things up. You can also use NSAIDs like indomethacin, which decrease urine output by the same mechanism it's used to cause acute renal failure at higher doses, by limiting renal blood flow. But one of the most important ways to manage both different kinds of diabetes insipidus, though, is to just keep them hydrated. If you're losing a lot of free water in the urine, you have got to have water on you at all times to replace the output with an equivalent input. On the other end of the osmolality regulation spectrum is the syndrome of inappropriate ADH secretion, or SIADH. It can be caused by pretty much any CNS disorder or trauma like strokes, hemorrhage, whatever, but one specific cause that pops up on the test all the time is a paraneoplastic syndrome that comes from small cell lung carcinoma. There's a bunch of other causes, but the only other one that's likely to show up on step 1 is the drug cyclophosphamide, a chemotherapeutic drug. While diabetes insipidus involves the output of copious amounts of dilute urine that leads to increased serum concentration, SIADH involves small amounts of hyperconcentrated urine that leads to serum dilution. But SIADH tends to be a bigger deal on the electrolyte front than diabetes insipidus. With decreased vasopressin activity, the tendency towards volume loss and serum concentration can both be adequately compensated for by increased thirst. True, most people with SIADH will drink less, but since people can't exactly drink salt water, any ingested water contributes to the problem of serum dilution. Meanwhile, aldosterone and its opposing hormone, atrial natriuretic peptide, which are also involved in maintaining fluid volume, are going to look at this expanded fluid volume that ADH creates and go, well, that ain't right. So aldosterone is going to decrease, and ANP is going to increase. And while that does offload some of the fluid, in doing so, they sacrifice more sodium because remember, they can't control the movement of free water. All they do is push sodium into the urine and hope that free water follows it out. And in this case, pushing sodium into the urine is exactly the worst idea because while it means that patients with SIADH have reasonably normal volume status, it exacerbates the problem of having significantly hypotonic serum. To reiterate, these patients are going to be euvolemic, but hyponatremic. Remember this designation of volume status. It can actually really help you work up your causes of hyponatremia. As you can see, this can be pretty problematic. A lot of times, if the sodium's low enough, they have to be hospitalized to have their electrolytes acutely corrected. Remember the main consequence of having hypotonic serum? While you can read the full list of symptoms in the renal section, the most serious consequence to know about is cerebral edema from water osmosing from the hypotonic serum into the more isotonic brain. So you've got to correct the hyponatremia, but you got to do so slowly. Remember, the hyponatremia is likely chronic, and the brain's adapted to living in these conditions to some extent. Correct it too fast, and you could get osmotic demyelination syndrome, a central demyelinating neuropathy that's most famous for causing locked-in syndrome.
The acute treatment for SIADH involves restricting fluid intake and IV hypertonic saline. But for long-term management, well, you got some options. Most people can get by alright by supplementing their sodium with salt tablets and by getting rid of some of that diluting water with diuretics. If you want to get a bit more exotic though, you can try the vasopressin receptor antagonists, also called the Vaptans. Get it? Vasopressin antagonist? These block the effect of increased ADH on the kidney, and you can recognize them because they all end in Vaptan. The other one is the drug I was telling you about earlier, demeclocycline, because it induces nephrogenic DI in high enough quantities, making it a good counter to an increase in ADH. Alright guys, this is a bit heavier on the physiology than most of my sections, so thanks for staying with me. Let's wrap this one up with a flash quiz.
In a patient with diabetes insipidus caused by lithium, how do you expect the urine concentration to change when desmopressin is administered? Go ahead and pause the video if you need some time to think about it. So remember, there's two kinds of diabetes insipidus. With central DI, the urine won't concentrate in response to dehydration, but the kidneys still respond to the administration of desmopressin. But because lithium causes nephrogenic DI, even the administration of desmopressin will not help concentrate the urine. We're going to wrap up our discussion of pituitary pathologies by discussing hypopituitarism, or the undersecretion of one or more pituitary hormones as a whole. We just spent a very long time going over the symptoms of multiple types of hormone deficiency, so I'm not going to go over what the symptoms are. Instead, I'm going to talk about what can cause the loss of multiple types of pituitary hormone at once. We went over this already, but what is the most common cause of hypopituitarism? We spoke about tumors, specifically the pituitary tumors that squish others out of the way without secreting any hormones of their own. Non-secreting adenomas are one variety, as are craniopharyngiomas, which are these neat little Rathke's pouch tumors, which are benign, very slow-growing tumors often found in kids that are a bunch of calcifications visible on CT. Finally, there's one pretty extreme cause of hypopituitarism caused by tumors, and it's called pituitary apoplexy. Have you ever heard of the term apoplectic rage? It basically means you get so mad your blood pressure skyrockets and causes you to bust a blood vessel in your brain and stroke out. Well, pituitary apoplexy is where a blood vessel in the pituitary bursts, but it's almost caused by the fragile blood supply of a pituitary tumor. It presents a lot like a subarachnoid hemorrhage with a sudden onset of severe headache, photophobia, nuchal rigidity, but there's a higher incidence of ocular symptoms due to optic and/or oculomotor compression. And while it can cause any constellation of pituitary dysfunction, the most common acute endocrine symptom is hypotension from adrenal insufficiency. Sheehan syndrome is anterior pituitary damage caused by infarction of the pituitary gland in women who've experienced a lot of bleeding during labor. And if that sounds like an oddly specific time to get a pituitary infarction, let me explain why that happens. First of all, I know you've not had your OB-GYN rotations yet, but when you see it, it is seriously incredible how much blood women can lose even during a normal delivery, especially during a cesarean delivery. It's not uncommon for women to lose over a liter of blood during the course of their delivery. Second, the anterior pituitary already has kind of a crummy blood supply when it comes to oxygen. Remember, because of the portal system, blood flows first to the hypothalamus and is partially stripped of oxygen before it reaches the anterior pituitary. Finally, the pituitary gland grows during pregnancy. Why, do you think? It's because of prolactin, in anticipation of the new baby. But the pituitary's hyperplasia and increased hormone synthesis mean that its metabolism increases significantly, so it's susceptible to demand ischemia just like an exercising or hypertrophied heart. Now, the combination of all three of these basically just causes the pituitary to give up and die if any one of them gets too severe. Now, there's a lot of changes going on at this time, and things like amenorrhea or low libido after delivery are totally normal, so you can't look at those and say, oh, maybe mom's got panhypopituitarism. The most immediately recognizable symptom, though, is the failure to lactate, which should prompt suspicion for hypopituitarism. Hypothyroidism as well is also something that should prompt that suspicion. Finally, there's empty sella syndrome, which is exactly what it sounds like. Either the pituitary is atrophied or flattened at the bottom of the sella turcica, making it look empty. While it can certainly be idiopathic, it's a condition that happens most frequently in obese women and is associated with pseudotumor cerebri. And just like that, we're done with the pituitary disorders. Stop for a moment and pat yourselves on the back, team, because now we're moving on to one of the most important endocrine disorders on the test, and in the United States, diabetes mellitus.